These inheritance patterns are commonly tested on certification exams, are essential for accurate genetic counseling, and form the basis of risk calculation, something families frequently ask about. There are 4 main inheritance patterns. Autosomal dominant. One mutated copy causes disease. Each child has a 50% chance of inheriting the mutation from an affected parent. Autosomal recessive. 2 copies are needed, one from each parent. Carrier parents have a 25% chance of having an affected child. X-linked. Involves genes on the X chromosome. Carrier mothers have a 50% chance of passing the mutation to sons, who may be affected, and a 50% chance to daughters, who may be carriers. Multifactorial. Involves multiple genes and environmental factors. Risk is less precise, but follows general patterns based on family history. Each pattern gives specific, predictable recurrence risks that guide decision-making in clinical care. Autosomal dominant inheritance occurs when just one copy of a mutated gene is enough to cause disease. Each child of an affected parent has a 50% chance of inheriting the mutation. This is because the parent has one normal and one mutated allele, and either can be passed on. This risk stays the same for each pregnancy, regardless of past outcomes. Both males and females are affected equally because the gene is on an autosome, not a sex chromosome. A key feature of this pattern is vertical transmission. The condition appears in every generation, so if a child, parent, and grandparent all show signs, think autosomal dominant. Remember, not everyone with the mutation shows symptoms. That's due to variable expressivity and incomplete penetrance, meaning the same mutation can cause different symptoms, or sometimes none at all. Autosomal dominant conditions follow a clear inheritance pattern. One mutated gene copy is enough to cause disease. Each affected individual typically has one affected parent, and there's a 50% chance of passing the mutation to each child. This risk is independent with every pregnancy. Most autosomal dominant conditions show vertical transmission, meaning the condition appears in successive generations. Both males and females are affected equally because the genes involved are on autosomes, not sex chromosomes. Although many cases are inherited, some, like achondroplasia, often result from de novo mutations, especially associated with advanced paternal age. This happens because continuous sperm production increases the chance of point mutations over time. Recognizing this pattern is key in identifying whether a condition is inherited or new, which guides genetic counseling, especially when there's no prior family history. Autosomal recessive inheritance often surprises families. How can 2 healthy parents have an affected child? The answer lies in carrier status and basic Mendelian genetics. Recessive conditions require mutations in both copies of a gene. Carriers have one normal and one mutated allele. The normal copy makes enough protein to prevent disease, so carriers appear completely healthy. Think of it like having 2 kidneys. You can function with one, but losing both causes illness. When both parents are carriers, each pregnancy has 4 possible outcomes: 25% chance of an unaffected child, 50% chance the child is a carrier, 25% chance the child is affected. These percentages stay the same for every pregnancy. Having several healthy children doesn't reduce the risk next time. Recessive conditions often skip generations because carriers are usually paired with non-carriers, so the disease doesn't appear. But when 2 carriers, especially blood relatives, have children, the condition can affect multiple siblings in one generation. This creates a horizontal pattern on a pedigree. Consanguinity means a union between individuals who are closely related by blood, such as first cousins. These pairs are more likely to carry the same rare mutation, increasing the chance of passing it on. First cousins share about 1/8 of their genes, and their children have a 3 to 6% risk of recessive disease, higher than the general population risk of under 1%. When a newborn is affected but both parents appear healthy, especially if there's consanguinity, autosomal recessive inheritance should be high on your differential. It also drives recurrence risk counseling and testing for siblings. Autosomal recessive conditions show distinct ethnic clustering patterns that directly impact clinical practice and screening approaches, evolved through millennia of population genetics. Cystic fibrosis affects 1 in 2,500 Caucasian births, with carrier frequency of 1 in 25 among Northern Europeans. This high frequency suggests historical selective advantage, possibly cholera or tuberculosis protection. Caucasian infants may present with meconium ileus, respiratory distress, or be identified through newborn screening. Sickle cell disease shows carrier rates of 1 in 12 among African Americans, reflecting evolutionary protection against malaria. These infants require immediate penicillin prophylaxis and careful fever management due to functional asplenia, though most cases are identified through newborn screening before symptoms develop. Galactosemia and PKU demonstrate how screening transformed outcomes. Previously, these conditions caused cataracts, liver failure, and irreversible intellectual disability. Early identification now enables dietary modifications that prevent devastating complications. Ethnic clustering guides diagnostic thinking. Mediterranean ancestry prompts thalassemia consideration. Jewish ancestry suggests expanded carrier screening for Tay-Sachs. These aren't stereotypes, but statistical realities, enabling targeted screening programs. This creates both opportunities for high-risk population screening and challenges requiring cultural sensitivity. Understanding evolutionary origins helps families process diagnoses within their cultural context while making informed reproductive decisions. X-linked family history patterns create diagnostic roadmaps that narrow differential diagnosis. These patterns emerge because carrier females transmit mutations silently, while affected males often cannot reproduce or die young. The classic pattern shows maternal grandfather to affected grandson transmission. Grandfathers with hemophilia have healthy carrier daughters who pass the mutation to 50% of their sons, creating an apparent skip generation pattern through carrier females. Carrier mothers demonstrate characteristic patterns: multiple affected sons, unaffected sons, carrier daughters, and unaffected daughters. Only males expressing disease despite maternal transmission. Specific examples aid recognition. Color blindness affects 8% of males versus 0.5% of females. Hemophilia A presents with prolonged bleeding from heel sticks or circumcision, with family histories revealing maternal male relatives with bleeding problems. Duchenne muscular dystrophy may show family history of maternal uncles dying in wheelchairs during adolescence, prompting early CK screening. X-linked lethal conditions create distinct patterns. Affected male fetuses cannot survive pregnancy, causing recurrent male pregnancy losses, while females survive to term. Conditions like incontinentia pigmenti show this pattern. Mothers experience multiple male miscarriages, but successfully carry daughters. This guides immediate counseling. When mothers report losing previous male pregnancies but deliver healthy daughters, consider X-linked lethal mutations. These daughters need genetic counseling before reproduction, facing 50% risk of carrying mutations that could affect future sons. Multifactorial inheritance represents the most common mechanism behind NICU birth defects, but is complex to explain. Unlike Mendelian inheritance with clean percentages, multifactorial conditions emerge from interactions between multiple genes and environmental factors. The threshold model explains this complexity. Genetic susceptibility acts like a cup that gene variants partially fill, each contributing small percentages. Environmental factors add more. When combined contributions exceed the threshold, disease manifests. This explains why some genetically predisposed individuals develop disease, while others remain unaffected. Neural tube defects exemplify this mechanism. Multiple genes affecting folate metabolism and neural development create baseline susceptibility. Environmental factors: maternal diabetes, medications, inadequate folic acid push susceptible embryos over the threshold. Folic acid supplementation modifies the environmental component, preventing many cases. Risk patterns differ from single gene disorders. Risk decreases with genetic distance as relatives share fewer susceptibility genes. After one affected child, recurrence risk approximates 2 to 3%, higher than population risk, but lower than Mendelian patterns. 2 affected children suggest greater genetic loading, raising recurrence risk to 10 to 12%. Severity correlates with recurrence risk. Hypoplastic left heart syndrome carries higher sibling risk than simple VSD. Bilateral cleft lip and palate indicates stronger genetic contribution than unilateral cleft lip. Clinically, we provide empirical risk based on population studies rather than precise Mendelian percentages. We emphasize modifiable factors and distinguish multifactorial patterns from major gene effects that might act more like Mendelian inheritance. Classification of multiple congenital anomalies into association, syndrome, and sequence represents fundamentally different mechanisms that guide diagnosis and genetic counseling. Mastering these distinctions enables effective communication with geneticists and accurate family counseling. Association describes non-random clustering of malformations without a single identifiable cause. Vater-Vacteral exemplifies this. Vertebral anomalies, anal atresia, cardiac defects, tracheoesophageal fistula, renal anomalies, and limb abnormalities appear together more than chance predicts. Clinical implication. Finding one component mandates searching for others. Esophageal atresia triggers renal ultrasound, echocardiogram, and vertebral assessment. Recurrence risks remain empirical since no single genetic cause exists. Syndromes represent patterns from single, specific causes, typically genetic, but occasionally teratogenic. The unifying etiology creates predictable multi-organ involvement. Charge or DeGeorge syndromes identify specific genetic defects with characteristic features. This distinction matters for counseling. Syndromes follow inheritance patterns, enabling precise recurrence risk calculations and targeted family testing. Sequences demonstrate cascading secondary problems from one initiating event. Potter sequence illustrates this. Severe bilateral renal disease causes oligohydramnios, leading to fetal compression that produces facial features, pulmonary hypoplasia, and limb deformities. The renal disease is primary. Everything else follows mechanically. These classifications guide clinical reasoning. Associations prompt comprehensive evaluations. Syndromes trigger genetic testing. Sequences focus on primary defects while managing secondary effects.